All right, just again, we've talked about this before, but I just want to go back and review it. Inotropic is talking about the force of the contraction. You can either have an increase or decrease, a positive inotrope or a negative inotrope. Chronotropic has to talk specifically with the speed of the heartbeat, so the heart rate, where a positive chronotropic agent will speed the heart rate up, negative chronotropic will slow it down. And you know what the definition of tachycardia and bradycardia is. Normal heart rate 60 to 100, less than 60 bradycardia, higher than 100 is tachycardia. This is out of your text talking about the sympathetic or adrenergic reaction to the heart. When you have sympathetic stimulation, you have an increase in heart rate, an increase in force of contraction. It increases speed of the impulse travels through. Parasympathetic or cholinergic would be exactly the opposite. We know that blood pressure is related to the cardiac output as well as to the systemic vascular resistance. And the way that we regulate blood pressure is by controlling one of those components somewhere in there. First one I want you to know is Digitalis or digoxin, that these are cardiac glycosides. They're actually derived from the foxglove plant, and these are positive inotropes but negative chronotropes. So we use it for somebody who has congestive heart failure. Did Judy talk about congestive heart failure yet? No, okay. Well, I use the analogy of the cart and a horse. If the load that is inside the cart is too great, the horse will tire out. A couple of things, there's three basic things we can end up doing. First of all, we can lighten the load. We can lighten the load by reducing preload, not having so much in the cart. I can also reduce afterload. And the analogy there would be, instead of going up an incline, find a road that's much more flat that the horse doesn't have to work as hard pulling up the hill. And the third component to that is using the whip, putting some force onto the horse by increasing contractility. So those three components of stroke volume can all be manipulated to improve the function of the heart. And in this case, what we would use, the whip, would be a cardiac glycoside, a positive inotrope. Okay? Make sense? So Digitalis or digoxin. And I only want you to know the generic names because I'm not going to get into the trade names. Some other ones that are cardiac stimulants, and these are adrenergic agents that have both a positive inotropic and a positive chronotropic, so they not only improve force of contraction, they improve heart rate. And the ones that are highlighted there are three that I want you to know: epinephrine, dobutamine, and dopamine. These are all medications that are positive inotropes. Somebody whose blood pressure is low and I want to improve it, I can improve it by improving the force of contraction, the contractility, through one of those drugs. In fact, we'll find that epinephrine is one drug that anytime you have a pulseless patient, epinephrine is an appropriate drug to be utilized. All dead people get epi. Epinephrine. Okay? No, epinephrine. I can just see you going to clinic and saying that, and people going, what? There you go. Another drug that is a positive chronotrope that just improves the conduction process by stimulating the sinus node to beat more frequently is atropine. And atropine is used to treat bradycardias and heart blocks. Okay. So if somebody has a very slow heart rate, comes in with a heart rate of 30 because there's a conduction defect where the impulse isn't getting through from the sinus node to the AV node to the Purkinje fibers, we can give them atropine to speed the heart rate up. It's a first line attack for somebody with a symptomatic bradycardia. How am I doing? So far so good? Now, antihypertensive agents, there's multiple ways that we can do this. The first way, and probably the most aggressive way, is with using a vasodilator. And the two that I want you to know are nitroglycerin and nitroprusside, both of which will rapidly reduce the blood pressure. They're vasodilators, meaning that they relax the smooth muscles surrounding the vessel, so it acts on the arteriolar vasoconstriction and dilates that. They're both nitrates in origin. Nitroglycerin we typically think of as the medication we use to vasodilate the coronary arteries when somebody's having an anginal attack. So somebody's having chest pain that's not relieved by them sitting down and relaxing. We can use a vasodilator like nitroglycerin as a tablet under the tongue to be able to vasodilate the coronary arteries. It can also be given as an IV medication as to nitroprusside, and it's a very, very potent vasodilator. So very quickly it'll reduce the blood pressure. Somebody comes into the ER with a blood pressure of 230 over 120, we need to get that blood pressure down as quick as possible. Yeah.
So that's reducing preload and afterload?
It reduces it does, but it's primarily reducing afterload. As another side effect, nitrates, what they also do is, yes, they do vasodilate and increase venous capacitance, meaning it increases the amount of blood that's left in the venous system, thereby reducing preload. But its primary action is as a vasodilator. Beta blockers, the one I want you to know is propranolol. Beta blockers, if I reduce the beta stimulation to the heart, I reduce the blood pressure. And there's a bunch of different ways that there's other beta blockers that are available, but that's one that I want you to know as far as this. Need to use caution, or need to at least be aware of, if I'm blocking the beta receptors. That also could be problematic in somebody with reactive airways. So somebody who's got profound COPD, they may have a bad reaction to beta blockade. So what do? We use one of the other avenues that are out there. And we're not going to worry about verapamil at this point. The most common way that we manage blood pressure is through the use of ACE inhibitors. If you go back and review your A&P, and we'll talk about this in the fall, because I spent a little bit of time talking about renal function. But in the cases where there's a reduction in what is interpreted as blood volume being reduced, or perfusion to the kidney being reduced, you have renin being released. Angiotensin is released by the liver, and renin is converted, or renin converts angiotensin 1 into angiotensin 2. That actually occurs in the lungs. The angiotensin 2 then stimulates the arterioles to constrict, and what basically would improve blood pressure. So if I block that cascade of events, I don't have that vasoconstriction happening. I can block it in one of two places. I can block the conversion of angiotensin 1 to angiotensin 2. So this drug actually works in the lungs, stopping that. Why the lungs? Because the lungs gets virtually all the perfusion that comes out of the heart. Makes sense. The good Lord made us right and put that conversion in that spot. Also, you can block the reaction of angiotensin 2 at its receptor site. And those are some other ways that we end up doing. Notice I do not want you to know any of these, but these are probably the most common way that we manage blood pressure on a patient who's got clinical hypertension. And valsartan, I think, is the one that I'm on. One of the ones I'm on. Going the opposite direction. Somebody who's hypotensive, I want to raise their blood pressure. I can do it using these medications which vasoconstrict. Most common ones are norepinephrine and dopamine. Dopamine we talked about previously It improves blood pressure by being an inotropic agent, which is that medium dose, but at high doses it actually acts like norepinephrine. It's a vasoconstrictor. At low dose, and I don't expect you to know the specific dose ranges, but just recognize that this drug, depending upon how much you're giving of it, it has different effects. With low dose, it's vasodilation of the splanchnic and renal vessels. Medium dose, it's an inotrope, which is where we primarily use it. And at a high dose, it can actually become a vasoconstrictor. It's a cool drug. We talked about anti-anginal, somebody who's having a reduction in coronary blood flow. We want to have a coronary vasodilation. Angina is defined as basically that chest pain that's paroxysmal. What does that word mean? Okay, comes and goes. It's a fancy way of saying comes and goes. So in other words, it manifests itself, and if the person relaxes and sits down and stops their exertional activity, the pain will go away. If it doesn't, then we may need to use an anti-anginal. The most common one there is nitroglycerin that you'll end up seeing. I have propanolol and verapamil noted there. We already talked about propanolol being a beta blocker. It's another way to treat angina. Calcium channel blockers are a third way, and scratch off verapamil. You don't need to know that just yet. Just a review of the heart's conduction system, starting in the sinoatrial node. It then goes through multiple pathways to reach the AV node. At the same time, the impulse travels across to the left atrium. Once it gets through the AV node, the impulse is slowed for a brief moment so that the atria can fully fill the ventricles. Then the impulse continues on through the bundle of His, through the major right and left bundle branches, and finally to the Purkinje fibers where they innervate the cardiac muscle itself. This should be old news, right? You had this in Mary's class. I know you did. Don't give me any lies. If that impulse is originating anywhere other than the sinus node, we're going to call that an ectopic beat. Ectopic meaning that it's not where it's supposed to be. They can arise any time during the conduction cycle. They can arise during the middle of a given beat. You can have a ventricular irritability that allows for a ventricular conduction to occur sitting on the T wave, which would be lethal. These are the reasons for the irregular beats, and they can arise from either the atrial, other than the SA node, or ventricular walls. And you guys remember the P wave, the PR interval, the QRS complex, T wave, ST segment. That's all. That should be drilled into your brain by now. And we know what the P wave represents, and what the T wave represents, and what the QRS complex represents. Just nodding your head. And if you don't, this is give you a little bit of a summary of it. Okay. So what can we do to treat these if there's a dysrhythmia that is present and is persistent, and it's causing and it's not relieved by simple oxygen therapy? So for instance, a premature ventricular contraction, or PVC, we can use various drugs to treat it. Let's just do two of these, the two with A, amiodarone and adenosine. Amiodarone is used primarily for ventricular antidysrhythmics. Adenosine is used for an irritable spot in the atria, what we would consider to be a supraventricular origin. So if I have somebody who has an atrial dysrhythmia, where it's something in the atria that is firing, and usually what ends up happening is it fires at a very fast rate. So I see a patient who has a heart rate of 180. Adenosine would be the appropriate medication to be utilized. It's atrial in origin. It is a narrow QRS complex. Amiodarone, on the other hand, would be used for somebody who has a ventricular origin of that beat. And we'll get to talking about how we know it's ventricular, things like there is no P wave, things like it's a very wide complex. I always say ventricular rhythms remind me of my first girlfriend. They're wide, bizarre, ugly, and don't work. Side effects of these agents include hypotension and conduction defects. There are multiple ones with multiple classes. Okay, leave it be. You can see that they act in various areas and work under different ways of doing it. I don't expect you to know that. This is out of your text, but for all practical purposes, it's more information than we end up needing. Anticoagulants, the two that you should be aware of are heparin and Coumadin. These are used to prevent clotting from occurring, and they promote bleeding. I mean, they interrupt the normal cascade of events that happens with clotting, that whole formation of thrombin. I think the only thing worse than, or no, the Krebs cycle, you know, the other one is the whole cascade of events that happens with clotting, prothrombin, thrombin. Yeah. Those are the antidotes you should be aware of. Both of them have antidote, protamine sulfate, vitamin K for warfarin. They're commonly used in atrial fibrillation, which I think you guys have covered in Mary's class. An area of the heart where the atria is firing chaotically, and because of that fibrillatory function of the atria and AFib, you end up having the potential to have clots form. Now, if a clot forms in the right atrium, it's going to go ahead then and get lodged somewhere in the lungs, a pulmonary embolus. If the clot is in the left atrium, potentially can get caught up in the brain, which is where we would have a stroke. Okay. So either way, that we want to prevent that, and we do that by using anticoagulation. Obviously, patients that are on anticoagulants require a longer hold time for any arterial punctures that you may end up doing. And then lastly, not lastly, there's some more slides here. The thrombolytic agents, these are used to break up clots. The first one is really the one that you'll end up seeing more, the first two actually, TPA, and tissue plasminogen activator is what it stands for. Yeah? Tissue plasminogen activator, meaning it basically interrupts with the clotting process and breaks the clot apart. Streptokinase and urokinase were older ones. These newer generation ones are very, very effective. We can use this for clots that occur in the heart. We can use this for clots that occur in the brain. So if we catch a stroke early enough, which is not necessarily the case, people present to the ER with a heart attack with chest pain usually within the first couple of hours. People come to the ER with signs of a stroke usually about 6-8 hours after it happened. It's too late then. You can't do much on that. So time is brain, as they say. And lastly, pulmonary vasodilators. These are ones that are used to treat pulmonary hypertension as opposed to systemic hypertension. And we'll visit inhaled nitric oxide again when we talk about neonatal hypertension. It's called persistent pulmonary hypertension of the newborn, PPHN. And it's a very effective drug to treat the hypertension that is present in the pulmonary system, secondary to hypoxemia. Prostacyclin and iloprost are two other drugs. Iloprost is one that you should be aware of. The trade name is Ventus. I give you how it's set up there. This is a drug that's an aerosolized pulmonary vasodilator. You probably will never administer this medication unless you work in a center that functions with pulmonary hypertension. So there's certain hospitals that have they're a center for pulmonary hypertension, and all the patients go there. Have you ever seen that, Amber? Yeah. It's a very fascinating drug. I would just like you to know that it's a pulmonary vasodilator. That's all I want you to know about it. If you ever happen to be in a spot where they're using it, then you can go back and review it. I don't think I would want to. Just saying. All right. Questions?